Hi, this is Eric Prystowsky. Welcome to another segment of EP on EP. I'm delighted today to have Dr. David Slotwiner here with me, who's the Chief of Cardiology at New York Presbyterian Queens in New York. And he's also, very importantly for our discussion today, the head of the Heart Rhythm Society's Health Policy Committee. And David, that's what I want to get into because you know much more about this whole area of shared decision making, certainly than I. And my understanding now is the new CMS policy with ICD implants, we're going to have to use this new thing. So take me through the journey, if you will, of what you had to go through to kind of work through this with CMS to get us where we are now, and maybe explain the difference of shared decision making versus what old Prystowsky's been doing for his whole career of trying to get informed consent.
Sure, my pleasure. So it's been a learning experience for me as well in my role as chair of health policy. When coverage policies are opened for review, we always write a comment letter on behalf of the society with recommendations that we believe should be included. The ICD coverage policy we had been asking to be reopened for many years. As you know, it was last reviewed in 2005, and a lot has changed. So we were gratified last summer when CMS announced that they were opening the coverage policy. And so we formed a working group, as is typical, and we reached out to our sister society, the American College of Cardiology, and together we wrote a comment letter with recommendations for what we thought should be included in the new policy, particularly focusing on the fact that we thought the coverage with evidence development requiring the registry had been answered, and that many of the waiting periods were having unintended consequences for patients. So we wrote that letter and we submitted it, and then there's a period where CMS takes the comments and writes a draft policy. So after 3 months, they released their draft policy, which we were pleased to see included our recommendations, but we were surprised to see that they also included a requirement that each patient have a shared decision-making encounter using a formal evidence-based shared decision-making tool with a clinician who would not be involved in the procedure.
Can I stop you just for a moment? This seems like it came out of left field. Did you think they would do this, or was there some rationale they gave you?
Well, you know, in hindsight, we should have anticipated it, but it did catch us by surprise. Yeah. Over the last several years, payers, including CMS, have increasingly turned towards this model of shared decision-making with an evidence-based tool. And to answer your earlier question, I've learned the difference between shared decision-making and the usual informed consent as we all know it is that a shared decision-making encounter is really supposed to be a model for patient-centered care, where patients are given in a user-friendly format of evidence, underlying evidence that creates the recommendation for the clinicians to give. And that evidence can be in the form of either PDF with pictures, an interactive website, or a video. And then patients are given exposure to that, and then in some manner their preferences, their healthcare preferences are elicited so that the combination can help them reach a decision that is most compatible with their preference.
So may I stop you for a second? So whatever this, we'll get into these certain vehicles or these tools, they actually have to go through the trial data, like the MUST, MADED, and all those trials, Danish, whatever. Does it have to get that specific, or could it tell us a little bit more about that?
Well, that's being worked out, and there are a few of these tools now available, and they do cite some of those trials. They don't go through all the evidence, but they do reach back to the underlying evidence that informs our decisions.
Okay, and again, just from a practical, I'm sorry to interrupt you, but from a practical standpoint, you and I both see patients. We're in an office, it could be a busy day, and let's say you have 2 people that day who are potential primary prevention ICDs. Do you have to do this actually while they're sitting in front of you, or can you let them review it another time? I mean, what are the rules around that?
Well, it's challenging, and the first thing I want to say is I have not figured this out, and I think we're all learning. It depends a lot on one's individual practice. There is a trial that is just starting called the DECIDE ICD trial, which is a randomized trial being run by Dan Matlock and Paul Rossi out of the University of Colorado, Denver, which is looking at this specific question, how to most effectively use the shared decision-making tools that they have developed in clinical practice. So I think it's still an unanswered question.
So one of the things that's important for both of us and our members who are actually seeing the patients is to answer their questions. So I'm looking at this and thinking, how do we get this done? I mean, unless you can maybe let them see it before you come in, or it becomes a real long office visit if you have to have them sit there and watch, right? I mean, and it's not fair for us not to answer their questions they're going to have.
Yeah.
So how do you see that flow going?
Yeah, I think some practices, such as Dr. Verosi's, have a sense of why patients are being referred. They come from a large geographical region beforehand.
Okay.
So they have their nurse practitioner actually share the shared decision-making tool with the patients in advance, and then the nurse practitioner will actually review it with them before they even see the physician.
That sounds like a reasonable way.
Yeah, and they found it to be enormously effective. They found the visits, the actual interaction between the physician and the patients to be more rewarding because you can actually get to a more meaningful discussion.
Right.
My practice is probably closer to yours in that I don't quite have as much advanced warning, and I have to date done a different combination of models depending on the individual patient.
So what works?
Well, I think
help me here.
Yeah, I mean,
because I'll tell you, probably you too. I think patients always think that their doctor has written a letter to us. I don't know about your experience, but when that happens, it's a hallelujah moment because I'll bet you 99 out of 100 patients who come to see me have no referral letter.
Yeah.
Right. So right, you come in, and you say, "Oh, Mrs. Smith's here today for primary prevention ICD." So you have much more experiences than I. What have you found that's worked a bit for you?
Yeah, so my practice is like yours in that I don't know. If I have time and if the patient seems appropriate, I will actually show them the video while they're there. And sometimes I'll watch it with them. Other times I'll leave them in the room, then I'll come back.
Maybe see someone else and come back and talk to them.
Exactly.
That sounds reasonable.
Others, I will give them the printout and ask them to review it. And then I can follow up. We do telehealth visits.
Oh,
so
really?
I can follow up with them by.
Okay, we aren't into that yet. That sounds very good.
It's terrific. Yeah. But I do have patients who just tell me they're not interested and don't do it. I work in the borough of Queens, the most diverse borough in the country.
Right.
So a good percentage of my patients do not speak English or Spanish. Wow. And so, there we don't have these tools translated into multiple languages. So I'm hoping for guidance from the DECIDE ICD trial, and I think it's very much a moving target. And I just would add, I think CMS, I give them credit for making the effort. I think when we saw this recommendation in the draft, we were all surprised, but none of us thought it was bad.
Right.
Who can argue with wanting to inform patients more?
Well, I agree. That it sounds reasonable. I hope they're giving us some period of time to work this out. I mean, as we speak, we're having patients set up. So do we have some leeway, some runway to get this right?
Well, technically, no, because
that's not good.
Well, CMS doesn't have that mechanism in its rules. It's very binary what they can do.
Okay.
So they cannot tell us that there's a run-in period, but a reality is we're all learning, and I think it was a good faith effort that we need to make to.
Well, you also, listen, to be fair to the process, you had some major changes that were very positive to patient care, and I, as a member of HRS, I want to thank you for your hard work on that, because there were some really sort of dangerous things to patients because of some of the previous rules with the DOJ, and I assume that was sort of part of the backdrop, right?
Yeah. Thank you, absolutely. We were
great
pleased.
work on that.
Thank you, and I should add, as everyone probably knows, we were successful in convincing CMS to remove the requirement that a clinician who was not involved with the procedure do the shared decision-making encounter. So now we can do it. We felt that was critical.
That is very good, because with the left atrial appendage issue, which we won't have time to go into, that's still a two-person procedure, right?
Exactly.
I want to thank you for your very hard work in this area. It's been a pleasure.
My pleasure.
Thank you so much, and thanks for standing up for the membership.